Bismillahirrahmanirrahim. Assalamu alaikum. Respected audience, today my topic of discussion is corneal ectasia in post photorefractive keratectomy patients. We received this 29-year-old young man who had undergone PRK in 2016. He also had a history of allergic conjunctivitis. Pre-operative, his surgery was minus 4.75 both eyes with minus 0.75 cylinders. And now recent, his visual acuity is 20/100, 20/60 and IOP is 16 both eyes. This is his latest refraction and contact lens prescription with minus 6.50 in the right and minus 7.50 in the left hard contact lenses. He had history of allergic conjunctivitis, so we prescribed him cyclosporine eye drops and olopatadine eye drops, and currently he's using tacrolimus and lubricants. Now this is this condition, this slide we have shown you that he is coning of the shear cornea, which can be appreciated, ciliary congestion and mild scarring in the center. This is another slide which is showing central scarring. And this is another slide which shows central scarring and ciliary congestion. So currently his pachymetry is right eye is 324, which is shown in this slide with central thinning, and in the left you can also see it is 346 and central thinning. So this is the follow-up corneal topography of this patient. When he presented to us, his Kmax was 63.2 and thinning of the cornea was 320 and posterior elevation was plus 75. Next slide. Here you can see the right eye recently on 7/2023, his Kmax has increased to 72.5. Thinning of the cornea has also further deteriorated to 290 and posterior elevation is plus 90. So in the right eye in 1 year, all the parameters have further deteriorated. Now let's see the left eye. The left eye has Kmax 65.5 and thinnest location you can see 348. While you can see that his left eye after 1 year, here in this slide, it can show that Kmax is 70.6 and thinnest location is 367, while his posterior elevation is plus 35. So in left eye, if we see the Kmax has also deteriorated by 4 diopters. So it shows that refractive surgery can cause corneal ectasia. For example, you see in this slide is shown that PRK causes relatively less and it develops after 5 years of surgery, while Lasik has some aggressive pattern, 6 to 18 months. There are some major risk factors to be kept in the mind. For example, if patient has foam frost, keratoconus, corneal degeneration, high astigmatism. So these are the risk factors, major risk factors. Pre-op corneal topography should be done, thoroughly studied. And one thing very important, if we are planning Lasik, we must keep in the mind that the corneal bed should be 200 to 325 micrometer bed should be there, even after cutting the flap. So if you go for a thick flap and take a chunk of the stroma, the bed will be less for you. So other thing is age. Usually youngsters develop these aggressive patterns, and if there is asymmetry in the both eyes and it is significant, he should be carefully observed before planning the surgery, because it is also important to keep the anisommetric patients in the mind. So currently this patient we are managing with allergy tacrolimus, mild steroids, lubricant eye drops. And once things get under control, inflammation settles down, we will go for deep anterior lamellar keratoplasty. Thank you.